Our first speaker will be Dr. Janice Verley, and she is director of a hospital in New York, and her major area of interest and clinical performance is infectious diseases. So Dr. Janice Verley will talk to us today about HIV/AIDS in women. Thank you. A round of applause.
Oh, that would be great. Thank you.
This is the USB.
Janice has got a pointer too.
It does. Oh, you see, you wait long enough and everything shows up. Good morning. Thank you, Dr. Smith, and the committee for inviting me to speak this morning. No, it's not working. Okay. So as we've briefly introduced ourselves, I am an HIV doctor right down the street at Hofstra University Medical Center. This is my first time speaking at this forum, so I wasn't quite sure how to focus my talk. It was a very broad category and overview of HIV in a short time, and so it's a huge topic. And what I tried to do, and I apologize because I'm going to be going quickly, not just because of time issues, but because I tried maybe to put a lot of different things in, is to just touch on a variety of different things that are involved in the HIV epidemic right now. Nothing too much in detail, and I guess at the end, I will have to leave before the end, so I'll take my questions before I leave. But thanks. So I'm starting from, a very basic, I don't know how many people in here know anything at all about these issues. So HIV stands for human immunodeficiency virus. And, why should we still care about HIV? There are a lot of competing healthcare issues out there. There are a lot of cost issues that are being discussed. And I think these are the two compelling reasons. It is a contagious disease, and it remains incurable. And I think when you have an incurable contagious disease, it behooves us to continue to pay attention to it and to keep it high on our priority list. I'm going to be speaking up. A busy slide, but basically what I want to point out is, how does HIV cause the infection that it causes? And I don't know if I can move away from the slide, but what it shows is basically a virus particle that attaches to a cell. This is a big cell. HIV infects many different cell types. The key things to remember is that the genetic material of the HIV virus enters into the cell, and it integrates into that person's cellular genetic material. And so this is how it can cause a latent infection. You may have heard that term, latent infection. These cells, once they're infected, they remain infected for the remainder of their lifespan. And so this virus can cause this infection that hangs around for a very long time, and it's difficult to eradicate, and the treatments that we have affect different stages of the life cycle of the virus. So what does it do? It incorporates itself, the virus incorporates itself into the human cell. It uses the body system to multiply itself. And in somebody who is not on treatment, billions of virus particles are produced on a daily basis. So there are stages of HIV, and this is important to remember. There can be a very long phase where there are no clinical symptoms whatsoever. The person doesn't feel well, doesn't feel ill, and they don't look sick. And this is the time when many people are transmitting that infection during that asymptomatic phase. The next phase, they develop a symptomatic infection. Fevers, chills, night sweats, weight loss. It can be very non-specific, nothing that somebody would pay much attention to. And then, of course, in the later stage, when the immune system has been significantly weakened, that's when you hear the term full-blown AIDS, when the person starts to develop what are called opportunistic infections. These are infections that cause disease in people where if their immune system was strong and competent, it would not cause a disease. So how do you get HIV? This is a key educational point to emphasize. These are the main ways. Unprotected sex with an infected partner, intravenous drug use using works that are not clean, and mother-to-child transmission. So crack, alcohol, crystal meth, anything that affects the person's ability to make choices about practicing safe sex practices or using risk reduction techniques will increase the chances of getting HIV. So you can't get HIV from sitting on a toilet seat on the New Jersey Turnpike. You can't get HIV from hugging somebody. You can't get HIV just from holding hands. And we want to emphasize that HIV is not just floating in the atmosphere. You can't breathe it in because somebody in the room has HIV. There are very specific ways of getting it. I was actually a fellow in Baltimore at the time when Magic Johnson indicated and came out and said that he had HIV. And the NBA spent a lot of money using persons like myself and other ID docs to go around to the different cities where they were playing the games and talk to the NBA players and their wives and give them education on, the fact that you can't just pick up HIV from touching somebody, etc. So amazingly, because I remember when we started talking about this gay men's disease, we are 30 years into the HIV epidemic. And there are many, many accomplishments, I'm very, very happy to say. And I've outlined some of the major ones. So we now have very easy and accurate and rapid tests to diagnose the infection, and that's a major thing. There is improved life expectancy here in the US and in developing countries. I'm going to show you a little information on that. A lot of this is because we now have simpler medications to take. And then we also have not just treatment successes and diagnostic successes, but we have prevention successes, and these are major. A major one that really, I started here at the medical center working on this issue of mother-to-child transmission, and we have basically eradicated that in developed countries, and increasingly so in developing countries. And we have pre-exposure prophylaxis and post-exposure prophylaxis to help prevent transmission before you may get exposed and after you get exposed. So this was kind of the poster child of somebody with AIDS. When you say, oh, the person has AIDS, this is what would pop into your mind in 1985, 1995. But in 2012, this is what somebody with HIV and AIDS, this is a couple with HIV and AIDS, and I think we all know now that you can't tell from looking at somebody that the person has AIDS. And Magic Johnson, of course, I think people recognize, diagnosed about 20 years ago on treatment, doing very well. So in 2012, actually, what are some of the big accomplishments in HIV treatment? We started with one drug, AZT, in 1987. Now in 2012, we have about 26 drugs. In the first 15 years of the epidemic, 8 drugs. In the second 15 years, another 18 drugs. And we now have combination pills available. So this handful of pills was pretty typical. In the early 1990s, somebody would be taking a big handful of pills 2, 3, 4, 5 times a day. Now we have one pill a day that can be effective in managing HIV infection. Remember, it's one pill, it's not one drug. So treatment of HIV requires combination therapy with at least 3 medications, and this one pill has 3 drugs in it. So the success of the medications, it's due to the sensitivity of the virus to the drugs. Patients must adhere to their regimen. It is key that when somebody goes on treatment, it is incurable, it is treatable. The virus will develop resistance and the medications will stop working if the person doesn't continue to take the medications as prescribed. So we spend a lot of time before treatment trying to educate persons about the importance of this. So increasing survival, prevention, mother to child, and I've mentioned some of these other benefits. These benefits that people can live longer, less illness, it's a way to bring people into care. When, back in the 1980s, why should somebody get tested? I'm amazed when patients still say that to me when I go on the hospital unit and I'd say, you know, maybe you should have an HIV test. I don't want to know what good is it going to do me. It'll do a lot of good. And you know, now we can feel comfortable saying that. Back in the 80s, you couldn't necessarily say the same thing. But all these benefits induce people to come into care. There is a real reason for yourself and for the broader picture to take treatment. 10 years after the introduction of combination therapy, at least 3 million years of life saved in the United States. It's a big thing. So in 1986, the median survival was about 10 years. Now, in 2012, we can say to somebody who's diagnosed at 20, you could live 50 years. You can have a normal life expectancy with HIV on treatment. And there have been several studies that have shown that. So I want to move and talk a little bit about women and babies. And again, I'm touching on a lot of different things. But this is one of the huge benefits that we have been able to have, is that women can now not just live longer, but they can have healthy children. And that was an issue for women. You know, they were traumatized by having the infection themselves, and further traumatized by the concerns that they could give the infection to their unborn child. So HIV in pregnancy, the landmark study was ACTG-076, and it showed that treatment could decrease HIV transmission. Now with combination therapy and some other things that we do in OB, the transmission rate less than 1%. We have not had an infected baby born at the medical center in more than a decade in women taking treatment. It's eradicated largely in the United States. And a big thing is routine testing in pregnancy. It is standard. You know, before women would go to their OB, they would say, you know, sort of shamefacedly, I hate to suggest it, but maybe you should take an HIV test. What woman wants to do that? No, I'm not at risk. I don't need an HIV test. Now it's standard across the board. Every woman gets offered, pretty much every woman accepts, they find out their diagnosis and they can get treated in pregnancy. That's how we're reducing transmission in pregnancy. This graph shows you that. Here you see the rising rates of transmission to a number of cases of pediatric HIV. It plummets after we start to use antiretroviral therapy in pregnancy. So there are downsides to the medication use. They are costly. They cost at least about $1,000 a month if the person doesn't have insurance. People really need insurance. There are toxicities, and I mentioned that there's drug resistance. I just want to mention this. This is a big syndrome that many people in the field of HIV are aware of. It's called lipodystrophy, and it causes some changes in glucose metabolism and increased cholesterol, but it causes these body fat shifts, so that what happens is the fat moves from the face kind of loses fat in the cheeks and in the temples, they lose fat in the arms, the veins kind of pop out, and then the fat kind of redistributes into the abdomen and the belly. And one of the concerns is that sometimes people feel that this change is very noticeable in their appearance, and that, you know, family and friends notice this change, and that it may actually make people think that they have HIV. So it becomes a stigmatizing issue. The other issue I want to touch on is the graying of the HIV epidemic. And you heard a lot about issues related to aging. So this is our clinic population, and now about 40% of the patients in our clinic are over 50 years of age. So HIV patients are getting older. And who thought that this would become the face of HIV? This is a 75-year-old woman. I lied, she's 73 actually. But she has HIV infection. And why is this happening? One, people with over 50 are getting infected with HIV. They may not think that they're at risk. They're practicing unprotected sex because they're not trying to prevent pregnancy. And so they're becoming infected, but also, as I mentioned, people are living longer with HIV, so they're just aging with the virus. And so this is, I thought, a very interesting statistic. This was in the New England Journal. By 2015, half of the US population living with HIV will be over 50 years of age. It's an older population. It's a very different sea change in how we manage HIV. And it's happening in developing countries as well. In Uganda, 40% can expect it to live into the 60s. Sub-Saharan Africa, 1 in 8 over 50 years of age. And so all the age-associated comorbidities that we were talking about, diabetes, heart disease, strokes, cancer, all of these things will now be interfacing with HIV, and we'll have to learn how to manage HIV in conjunction with these conditions. Hepatitis C, a very big secondary epidemic that's interfacing with HIV. About 30% of people with HIV, certainly in our clinic, are also co-infected with hepatitis C. And what happens? The HIV virus can make the hepatitis C harder to manage and similar. So they are intersecting epidemics, and we're just going to be seeing more and more. And in fact, liver disease is one of the leading causes of deaths now in persons with HIV infection. Some numbers I think to keep in mind, there are about 50,000 new infections per year in the United States. About 1.2 million people living with HIV and AIDS in the United States. About 20% of people infected with AIDS, still with HIV, don't know that they have the infection. And about 50% who know that they have the infection are not in regular care. And this is just showing some of the states, the top 10 states that have cases of HIV. And as you would expect, it's the big states, California, New York, Florida, Texas. But where is the rate, the number of cases of HIV per 100,000 the highest? The District of Columbia. Look at that rate. 112 persons per 100,000. This rate is similar to the rate in some countries in South Africa. Very high rate, very high rate. You know, what are the risk factors? This is from the Centers for Disease Control. The big yellow section is men having sex with men. So the leading transmission categories of how people are getting HIV in the United States, 61% MSM, and then that 30%, 18% and 10%, 28% is from heterosexual contact. So those are the two largest transmission categories, men having sex with men and heterosexual contact. When we look at, if we break it out by sex, how are men getting infected? 3/4 of them from having sex with men, 12% from heterosexual contact, the rest from intravenous drug use. Women, it's almost all heterosexual contact. Almost 90% of women getting HIV from having sex with men who have HIV infection, and 14% is intravenous drug use. The other key thing to remember is that HIV is disproportionately affecting certain ethnic communities or ethnic groups. So 65%, this is the overall US population, 65% is white, but new HIV infections, only 32% are white. Blacks make up 12% of the US population, but they make up 44% of new HIV infections. Hispanic, 16% of the US population, 20% of new infections. So blacks make up a disproportionate number of new HIV infections. And when we look at women, here you see white women make up about 70% of the US population, but only 18% of HIV infections. Black women, 12% of the US population, and about 2/3, 66% of HIV infections. Again, blacks disproportionately and Hispanics disproportionately affected by HIV. The proportion of HIV and AIDS diagnosis in women, it rose through the early 90s and is now at about 1/4 of HIV and AIDS cases are in women in the United States. So to look a little bit at a bigger global picture, this is from UNAIDS, you see that the United States numbers are a drop in the bucket to what's going on globally. Number of people living with HIV, 33 million. I told you that here in the United States we're about 1.2 million. So we're about 4% of the global numbers. Newly infected, 2.6 million. We're about 500,000. We're about 2% of new infections. So yeah, we have a problem here, but it's small in comparison to the global disease. I'm going to jump that. Over 7,000 new infections a day in 2009. This is the most recent data from UNAIDS. 97% of these new infections in low and middle income countries. 1,000 are in children less than 15, about 6,000 are in adults, of which half of them are in women and 41% are in people who are 15 to 24 years of age. So we, the United States, very involved in paying for HIV care globally. And I think I just wanted to briefly mention so that, I think everybody's aware, this President Emergency Plan for AIDS Relief, or PEPFAR, which was initiated in 2003 with $15 billion doing prevention, care, and treatment, and it prioritized these low-income countries with high HIV prevalence. So for global health initiatives, PEPFAR is 80% of the funding that's spent in the US for these global health initiatives. 80% is that PEPFAR HIV program management, and 12%, 20% is other initiatives. This is global HIV rates. The redder it is, the higher the prevalence. And you can see, as you might expect, sub-Saharan Africa, parts of Europe. This is the United States here, a little bit pink. So again, disproportionately in those areas. Then this is where the PEPFAR programs are. The larger numbers are in blue and this umber color. And again, so you'll see that the PEPFAR programs overlap where there's a high prevalence of HIV. So they've targeted the money to the areas with the high HIV prevalence. Core principles, the first one, focus on women, girls, and gender equality. This is a core principle in terms of how this money will be spent. Encourage the countries to become owners and to invest in country-led plans. So they want these developing countries to start to take the lead in managing HIV infection. And key, they want to build sustainability, developing and strengthening health systems and infrastructures so that when they pull the money out or pull the money back, these countries may be able to sustain and continue with these issues. Results have been significant. About 4 million persons getting antiretroviral treatment, almost 10 million pregnant women tested, decrease in mother-to-child transmissions, 13 million persons provided care and support, HIV counseling and testing for 40 million persons, averted approximately 1.1 million deaths in Africa and reduced the rate due to AIDS by 10%. So they are seeing dramatic results from this investment in developing countries. Where are the key countries now receiving antiretroviral therapy from PEPFAR? These are the top 10 countries. South Africa, Kenya, Nigeria, Zambia, Tanzania, and you see the numbers. In South Africa, over 1 million persons on antiretroviral therapy paid for through PEPFAR money. They're seeing the same issues that we are with being able to keep people on medicines. This is over 48 months, initially 100%. By 48 months, look at the dramatic drop. So they have to focus energies not just on starting people, but being able to keep people on the medications. And looking at, this is the red bars show the increase in persons on antiretroviral therapy. The line shows the decrease in rates of TB. So as you treat people and their immune system strengthens, you see drops in the rate of tuberculosis. You treat people, you see rises in the rate of antiretroviral therapy, death rates come down. And this is looking at, those are PEPFAR countries, focus countries. These are control countries not getting PEPFAR money. The rates of death have come down, they've plateaued down. Here in these control countries, the rates of death are not coming down. This is from HIV. So quickly, HIV is preventable. What do we do to prevent it? Condoms. There are male condoms and there are female condoms. Microbicides are in development. Why are microbicides important? They're useful for women who are unable to insist on their partners using it. So for male condoms, the male has to agree to do it. Even with female condoms, they usually have to have buy-in. But with these microbicides, which are gels or creams that the women can put on, they don't necessarily need their partners to agree or to participate. Important to take the test. The tests now are quick, easy, rapid, accurate. A finger stick test can give you the result in 20 minutes. An oral swab can give you the result in 20 minutes. The last thing I'm going to just briefly touch on, HIV in women, some of the issues. Domestic violence, I think a key issue of how do we get women in care, how do we get women to test, how do we get women to sort of stay in care. And then the last thing, stigma. I don't think we can talk about HIV without mentioning that. And I put this picture out just to say that domestic violence affects everybody. Whether you're rich, you're poor, you're a celebrity, you're not. You never kind of know. You can't just look at somebody and guess that they could be a victim of domestic violence. Stigma, we need to try and make sure that we're addressing that. I wanted to close just on a quick and brief case which I think highlights some things. This was a case from 1998. I saw her in 1999 just quickly. But the issues are still very relevant and resonate. Basically, a 48-year-old black female. She was diagnosed after her husband was in a car accident. Her husband was driving, I think, on Hempstead Turnpike, ran his car into a pole, came to the emergency room. They did a CAT scan on his head, and they saw a big abscess in his head. Admitted him to the floor. We found out that her husband had toxoplasma encephalitis and full-blown AIDS. It turned out that he knew he had AIDS for quite some time, and he was taking his medications, which were in the drawer at home. He had never told his wife, who he was living with for many, many years. So now she comes into the hospital, she's visiting him, and we spend weeks trying to ask this man to tell his wife that he has AIDS and she may have HIV and that she should be tested. He never really does. He never leaves the hospital, unfortunately. This is back in 1998, people died. So he died, and literally like a day or two on his deathbed, he tells her that he has HIV infection, and she is devastated. She has 2 young kids. They were 5 and 6 at the time. She's lost her husband. She finds out he has AIDS. She finds out she may have HIV. She takes the test, and lo and behold, she is infected. So she is, totally shook up, and she decides not to have her sons tested. What? Interestingly enough, she said they were 5 and 6 and they were healthy at the time. Her sons are now in their, 20s, and never had them tested, has never told them, never told anyone. She's only told her sister. She had strong Christian beliefs, no real support group, didn't want case management, only a sister knew her status. She briefly started treatment, but she felt okay. She couldn't deal with it. Every time she came to the clinic, it reminded her that she had the problem, so she left. 2007, she came back in. She was seeing a primary doctor. She had thrush, she had weight loss, she had sinus infections, and sure enough, she had full-blown AIDS. Her CD4 count was low, and I spoke to her. I said, you need to go on treatment. Surprisingly, it took some convincing, but she went on AAA, CD4 count came up, and she is doing great, and continues to do great, but continues to live a life where her HIV diagnosis is her own. She still has not really shared it with anybody, and still deals with issues of stigma and discrimination and concerns and fear about anybody finding out this diagnosis. So I'm going to stop there because I probably ran over, but thank you for your attention, and I'm open for questions.
One thing I want to remind everyone, we're asking everyone in the United States on June the 27th, which is Wednesday, is National Take the Test Day.
Yeah, National HIV Testing Day. So you'll see from time to time, there's National Black HIV, Awareness Day. There are multiple different ones, but National HIV Testing Day is always, I believe, June the 27th. And I think it is important to highlight and to focus and to, get the word out for people that all the community health centers associated with Nassau Healthcare Corporation, the hospital, you can go to almost every healthcare facility and get an HIV test and a rapid HIV test.
Oh, that's what I
Janice, thank you. Thank you. From the Global Associates to you.
Thank you very much. Yes, you have a question?
Yes, the rapid testing you were talking about, I know they give that at NYU, and they were doing that as part of like a research project for the students that were there. And it was like you had to wait a week after you had contact with someone or something like that, and then you take the test, and then I think it takes a week. I don't know if you can explain more about it, and do they have the rapid test available, in Long Island, and not just part of a research that the students at NYU were doing?
Okay, so I'm sure that there are many research projects going on. Rolling out of what's called routine testing has been a process. In 2006, Centers for Disease Control put out a paper indicating that we should increase access to routine HIV testing, which means that it should be in general medical health care settings. When you go to your primary care, when you go to OBGYN, when you go to the pediatrician. That took a while, and actually in September of 2010, New York State made it a law requiring that in primary care outpatient settings and in hospitals that HIV testing be offered as a routine. Now, so that is now the law in New York State, and most hospitals are in the process of working with the Department of Health to implement that. Prior to that, there were many studies where different settings, especially emergency rooms, were looking at trying to implement it, to routinely offer it to everybody who came in. I mean, clearly there are logistic and cost issues for doing it. People may have insurance, they may not have insurance. It requires, and remember in the beginning, when I started, HIV counseling and testing was a 20 to 30 minute process. You sat down in a separate room and you went through a whole checklist of 20 things that you had to talk to the person about. Clearly we couldn't do that as a routine. So they've streamlined the testing to allow it to be integrated into routine practice, and that's now the case here. So in pretty much any healthcare setting, at the medical center, North Shore, there are the Department of Health sites. Any of those sites you should be able to go. There would be, you can Google, I don't know the number off the top of my head. Anywhere in New York State, they'll give you a 1-800 number. They'll tell you the closest site to you where you can go and get HIV testing. And needle stick or swab, it's set up, the result will come back. Now, what happens is if the test is negative, you get the result immediately. Your test is negative, yes. Are you pointing?
Microphone.
Oh! Okay, if the test is negative, you get that result back in 20 minutes. However, if it's a preliminary positive, you're told that it's a preliminary positive and that they need a confirmatory Western blot test. So that is still the case in most settings where we're testing. And so for that test will then be sent out, and that could take another, say, 2 to 3 days. So you're either told that the test is negative, or that it's a preliminary positive, which we don't know the exact significance, because some of the preliminary positives are positive, but some are negative, and you do need that confirmatory Western blot test.
Okay, so when they do the test, then it's like this specific test, I don't know if it's called RU or something, it was like you have to, it was like after a week after exposure, let's just say somebody had sex on Monday and then you had to wait till the following Monday to go take the test.
Okay.
But aren't most tests you have to wait like 3 to 6, whatever the gestation period is before?
Right. So you're talking about what we look for. Generally speaking, when we test for HIV, we can test for 2 things. We can test for the antibody, which usually takes, say, at minimum 4 to 6 weeks to develop. Or you can test for the virus multiplication in the system itself, and that will happen, you know, certainly sooner. So there is what's called a window period, and that's the period from when you get infected until that antibody develops. And so you could be exposed, you could be infected, but the test could be negative. And that's why anytime you have an antibody test, they'll say to you, if you have had any recent you know, risk behavior, unprotected sex, etc., you should retest, you know, say in 3 months, to ensure that you pick up that result. So again, I don't know the details of that study, but yes, there is a window period, there is a point where you could be infected where the serology test would not identify it.
Excuse me, a question I want to ask is there any lure being developed where a partner have to let their partner know that they're HIV or AIDS?
Okay, so in New York State now the way it works is once somebody is diagnosed with HIV and we tell them that when we test them, their name automatically goes to New York State. So New York State knows the names of everybody who's HIV infected. And we say to them, you may be contacted by somebody from the county to talk to you about this. And we ourselves, so we tell them that and we ask them, it's voluntary. I mean, nobody's going to get thrown in jail for not reporting the names, but we are required to ask them the names of persons that they have been, you know, they may have exposed. And we tell them that the county may do that as well. And if a name is provided, we can, the person themselves can tell their partner, we can notify the partner, or the county can notify the partner. And when the county notifies a partner, they never use the name of the person. They simply go to the person and say, we have, you know, information that indicates that you may have been exposed to HIV, and we suggest that you have an HIV test.
Thank you so much, Doctor.
Okay, thank you.